All right, I'm going to be doing the competency for history taking, and I've taken the history of a patient during class. I'm going to report my findings. Their number one chief complaint is left anterior hip pain, and when they have described where it is, they've pointed to the tensor fasciae lata region, and deep to the TFL was stated. It was provoked, as they say, provoked by movements that they show that are hip flexion related. So things like squatting and lifting their leg and hip into hip flexion. The pain appears to be localized based on what they've stated, and it is a sharp sensation. It started a year ago. Ever since then, it's been more episodal, but there is always an underlying pain, but the episodal pain increases to a much higher VAS. It would be considered more chronic type pain. Pain has not changed since onset, even though it's episodal. It's aggravated predominantly by cycling, and there's no previous treatment that's been attained. It's also associated with stiffness of the same side hip and snapping sensation inside the hip in the same region of the pain. This is provoked by external hip rotation or a Faber type movement. Pain is currently there and is mechanical in nature. Medical history shows that this person has been diagnosed with what they've termed as a connective tissue disorder and stated that it is not Marfan's and it is not any other term other than connective tissue disorder. That's what the doctors have termed it. Surgeries, they've had spinal fusion of L5-S1, including a microdiscectomy of L3, L4, and replacement of L4 and L5 in, that's the disc, L4, L5 disc, in 2014, and now has recovered from that back pain. There are no scans of the hip, no current medications. The musculoskeletal review shows headaches that relate to eye strain off and on, but not current. Lower back stiffness, but no pain. Abdominal wall weakness since the surgery, and they're working on core strengthening currently. Genitourinary, we looked at that. No pain with urination, no bleeding, no elevated frequency of urination, and they are continent. Gastrointestinal system, abdominal pain and bloating after eating bread, but no relationship with the abdominal pain with mechanical causes. Differential diagnosis is either an iliopsoas or rectus femoris tendinopathy, hip acetabular labral tear, or a femoral nerve pain, either due to localized entrapment or because of a radiculopathy. My examination includes the following: observation of the lumbar, thoracic, cervical, and lower extremity, postural abnormalities, atrophy, any skin lesions, etc., asymmetry. Range of motion assessment of the lumbar and thoracic and hip, and knee and ankle due to things like cycling being a problem. Check for range of motion deficits there. Palpation of the lumbar musculature, quadratus lumborum, iliopsoas, tensor fasciae lata, gluteus minimus, medius sartorius, and also nerves, femoral, obturator, lateral femoral cutaneous nerve, and then of the actual joint line to palpate the labrum. Fair, so special testing, we'll do a quadrantal fair test, Faber test, scour, slump test to rule out any sciatic or lower lumbar sacral plexus problems, or radiculopathy or disc. Femoral slump, Trendelenburg to look at any instability through the pelvis. Anterior to posterior, posterior anterior glides of the hip and of the lumbar spine. See if there's any referral or if there's any replication of pain in the hip. Kemp's test in the lumbar. Active resisted hip flexion test. Internal rotation, active resisted, external rotation, also in hip flexion. Gluteus maximus and gluteus medius, active resisted, more so to see if there's any weakness that might be associated with the problem. Sartorius, active resisted, see if there's any tendinopathy of sartorius or a lesion of sartorius. TFL, Same for that, knee sartorius lesion, TFL lesions. Knee extension, active resisted, looking at rectus femoris to sort of differentiate between rectus femoris and iliopsoas testing. Adductor strength, active resisted, just in case it's a sort of a weird positioning for the pain, even though it's an adductor tendinopathy or lesion. Reflexes, patella predominantly because of the location of the pain, and sensory testing, medial, anterior, and lateral thigh. Reported findings are as follows. Observation of the lumbar and thoracic, cervical, and the lower extremity showed diminished lumbar curve and slight thoracic hyperkyphosis. The rest were normal. Lumbar range of motion demonstrated a reduced range to the left in rotation. All other ranges were normal. Segmentally, we found that it was the L5 and L4, both had motion restriction to the left. Hip range of motion has pain was provoked actively with hip flexion. No other motions were painful. Knee and ankle were all within normal limits. Palpation of and hip ranges and thoracic and lumbar were all within normal limits, other than the hip flexion and rotation, that's stated. Palpation of the lumbar, we found that there was some asymmetrical tightness in the lumbar spine, predominantly on the right, so QL and lumbar musculature. On the left side hip, TFL, glute min, sartorius were all hypertonic, but mild to no tenderness. The femoral nerve was tender to touch, but the obturator and lateral femoral cutaneous nerves were not. The joint line was tender to touch, but they are very close together, close to the femoral nerve, so it's hard to differentiate. The Thayer test and the Faber test were all positive. The deep anterior hip pain slump test was negative. Scour test was positive with Faber. Femoral slump was positive, and Trendelenburg was positive as well, but only mildly. Hip glides were negative. A little bit of A to P restriction on the hip, but generally no pain. KEMS was negative. Active resisted hip flexion was positive, but not as much as fair. Internal external rotation negative. Glute max, glute med, both weak. Sartorius negative, TFL negative, knee extension negative, adductors negative, reflex, patellar reflex was negative, and sensory testing was mildly different on the same side, on the left side, particularly anteriorly. So that does rule in the femoral nerve sensory branch. That may be involved. So my differential diagnosis, as I've stated, was iliopsoas tendinopathy, femoral nerve and hip labral. Because we don't have any scans, we can't really differentiate between a tendinopathy and labral, but I would suggest there is some femoral nerve involvement, whether it just be to do with localized inflammation. And the way that I would work through this case, would be to look at improving A to P glide, because that was limited relative to P to A glide, improving glute max and glute med strength. That will help to stabilize the hip more. We'd also do some strengthening of the iliopsoas in order to create some more stability in the hip. Iliopsoas has a stabilization effect through the hip itself and improves P to A glide as well, according to papers I've read. We also do some core stability, but that's already been done, so it's not so important. The adjustment might also be to the lumbar spine, because there was a restriction in L5 rotating to the left, so probably do an adjustment P to A, same side mammillary push with a hypothenar contact. On the, because the right to left, would do the right side laying on their left side. And that's my reported findings and history taking. Thank you.